First up, we've got Yoshi Okubo from NEURA. He's a research fellow there from the Falls Balance and Injury Research Centre, and he's going to be talking to us about ReactStep, a novel reactive balance training program for clinical settings. Yoshi.
Thank you very much for this wonderful opportunity. So trips and slips are the major causes of falls in community-dwelling older people. So that's our target in our intervention. So reactive balance training uses repeated postural perturbations to stimulate the balance. And there is preliminary evidence to show that reactive balance training can prevent falls very effectively. The main issue of this training is that you need equipment, which is often not accessible. And even the commercially available treadmill, perturbation treadmill, is very expensive. So we wanted to design a low-cost program that can provide reactive balance training. So I'm going to show you a 3-minute video.
Reactive balance training more affordable and accessible. We have developed the ReactStep program using low-cost equipment based on scientific evidence. The ReactStep program incorporates the key components of reactive balance training, including rapid reactive stepping in multiple directions to initiate appropriate balance recovery responses. To complement this training, intentional slip and trip training and functional strength training have also been included to further enhance the training effect. Studies have shown repeated practice of reactive and elevated stepping can improve balance recovery in response to an actual trip. High dosages of intentional slip training have also been shown to provide effects comparable to low dosages of unpredictable slip training. This component is particularly useful for clients at risk of falling or are afraid of falling. Evidence suggests that these benefits may be enhanced by incorporating strength training targeting the key muscles employed in reactive stepping. The tether release section of ReactStep is an individualized program that trains multi-directional reactive stepping responses. This involves tether releases using a wrist strap connected to a digital scale, release shackle, and rope attached to a stable structure. A foam block with an appropriate height will be placed in front of the participant's feet to guide an elevated stepping trajectory, critical for successful recovery when tripping on an obstacle. The client will be instructed to maintain a straight body posture and gently lean forward. When the tether is released, step over the foam obstacle and regain balance within 3 steps. The starting intensity is 5% of the client's body weight held by the rope and is increased or decreased according to the capacity, confidence, and progress of the client. The same procedure will be repeated for forward, lateral, and backwards directions. As an additional cognitive challenge, the client may be asked to remember given words on a specific topic, such as fruits, animals, and countries, and recall them after each trial. Intentional slip and trip training provides an opportunity to learn effective stepping patterns at the client's own pace. Trip training will involve intentionally striking a wooden obstacle to develop an automatic foot lifting response by flexing the knee and hip above the obstacle. Intentional slip training trains the neuromuscular system to control balance while sliding and take directed steps in order to maintain balance. A low-friction plastic sheet is placed under the foot for the client to slide towards an appropriate target distance. Clients may then commence trials with appropriate steps to gradually increase sliding speed to enact reactive stepping for balance recovery, similar to an actual slip.
Okay, so we've conducted a randomized control trial starting with 80 older people living in the community without any neurological conditions. Both intervention and control group received the home-based strength training using resistance bands twice a week. And the intervention group received the ReactStep program given one-on-one with an exercise physiologist once a week for 6 weeks. And we assessed reactive balance, gait, maximum step length, strength, postural sway, and reaction time at baseline and after the intervention. So the adherence was really good for both reactive balance React Step program and home-based strength training, both above 90%. And in terms of how participants perceive the program, it's good to have some challenge, but the anxiety, we wanted to keep it low. So 80% of the participants had at least mild fear of falling in our study, and they had just a little to mild anxiety during the training, which also improved, reduced during the 6 training sessions. And they also had high enjoyment in participating in the React Step program. In terms of physical outcomes, they significantly improved the usual gait speed, maximum step length, and step reaction time, which was really good. And during the training, so the tether release loading increased significantly. So participants were more confident to lean forward, sideways, and backwards during the course of the training sessions. And this was the primary outcome. We wanted to see if the participants who were trained on the React Step program could recover from trips and slips. And unfortunately, this participant could not recover from the unpredictable slip perturbation, but he did very well on the tripping response. So that was the exact movement he practiced. So this is the reduction was not significant, unfortunately. So in conclusion, React Step program showed little to mild anxiety, high enjoyment, and excellent adherence in older people. And the program improved gait, maximum step length, and reaction time, known as significant risk factors for falls in older people. Tether release balance recovery improved, but this did not sufficiently transfer to unexpected trips and slips. So further studies, we're currently following up on their falls in daily life, and also we're looking at feasibility in clinical populations. I'd like to thank everyone involved in the study and the participants. Thank you for listening.
Okay, we'll go quickly, but does anybody have a question for Yoshi? Can't see anyone. Anything on Slido, Dana? No. I think you're clear. Thank you. Thank you, Yoshi. Okay, our second speaker today is Chiara Mastrogiovanni. She's a master's student at the discipline for psychiatry and mental health at UNSW, and she's going to be talking about an online health promotion program targeting social support, physical activity, and fall prevention for older people. Welcome.
Thank you. So both falls and mental health, as I'm sure we're all aware, are priorities for older adults. There's also a bidirectional relationship between falls and mental health. An increased falls risk can lead to poorer mental health outcomes, and furthermore, psychological distress, depressive symptoms, and antidepressants are all risk factors for falls independent of each other. Physical activity has already been proven as a useful approach for older adults with poorer mental health and to improve falls risk. Additionally, social media is a feasible method of delivering physical activity programs. In 2020, our team conducted a pilot study that found our physical activity and lifestyle program to be feasible and acceptable. Last year, we enhanced the design of the program used in the pilot study by adding Neura's Standing Tall program, creating Moving Together. Standing Tall has demonstrated efficacy for rate of falls over 2 years, however had no effect on psychosocial outcomes. A qualitative study further highlighted that while participants valued being able to doing exercises in their own time at home, many participants highlighted the lack of social connection as a limitation of the program. We've recently published in Trials our protocol paper for the Moving Together randomised control trial. The Moving Together program has 3 essential components: a Facebook-delivered healthy lifestyle education and support program, an e-health falls prevention program, Standing Tall, and an aerobic and strength exercise program tailored to each individual participant. The program required participants to join a private Facebook group for 10 weeks. Each week had a specific topic focus, and participants were provided with resources and facilitated to engage in discussions with others in the group. Topics included goal setting, overcoming barriers, balance training, increasing structured exercise, and healthy eating. There was also an option for participants to join a weekly group video call. The study aimed to determine whether this program was effective at improving primarily psychological distress as evaluated by the Kessler-10. Secondary outcomes included self-reported physical activity levels, social capital, concern about falling, loneliness, physical functioning, physical activity enjoyment, and quality of life. Participants were randomised to either the intervention group or waitlist control and completed questionnaires pre, post, and at the 1-month follow-up point. We had a high response from older females, accounting for 89%, with a mean age of 66 years. And as the trial was online, we were able to recruit from all over Australia, but particularly from New South Wales. So what did we find? The intervention group had a program completion rate of 59%. 64% of all participants completed post-program questionnaires, meaning 36% dropped out. Each facilitator-initiated post was viewed on average by 43% of participants, which was 73% of program completers. At week 10, there was a significant improvement in the primary outcome of psychological distress in the intervention group compared to the control, but this wasn't retained at the 1-month follow-up point, and there were no significant changes in secondary outcomes. Although there are some limitations, dropout rate may limit the power of our findings. Process evaluation data like Standing Tall adherence is yet to be analysed. Additionally, it was likely that most of our sample were considered technologically literate and willing to take part in a physical activity program. This trial has implications for the recruitment, engagement, and delivery of physical activity programs targeting mental health in older adults. Future trials might aim to focus on exploring methods to increase retention. Considering digital delivery via social media has the potential to be low cost, low resource, and reach those in rural and remote areas, this is another area that could be explored, as well as looking at balance training as an adjunctive tool in similar mental health programs for older adults with the added benefit of improving falls risk. The same can be said for the reverse, with the potential of targeting mental health as a strategy for falls risk. And I'd just like to thank my supervisors and our collaborators. Thank you.
Thanks very much. Very, very clear, very concise. We do have time for a question or two. If anyone's thinking of one up, my question would be about the adherence and what are your suggestions of how you can actually get, improve adherence to and the retention for the program?
Yes, so we've been recently interviewing our participants, and something that was, hard to balance was a lot of it was for mental health, so we didn't want to be, on their back too much. We wanted them to still feel happy about their achievements and feel like, anything is better than nothing with physical activity. But at the same time, feedback we've gotten so far was actually some people saying, no, I would have wanted you to be on my back a little bit more. So kind of maybe even just talking to participants individually and seeing what they want and targeting from that way.
Thank you. There's one more question, I think. Is there a Slido question?
There's a question on Slido that asks, what was considered a program completer?
Yes, so completing the program was considered staying in the Facebook group by the time our last post was made in week 10. So they could leave the group at any time. but we also sort of want to look at the data that shows how many people actually viewed posts, including the last post, because of course there's a few different ways we can define that. So that'll be interesting when we look at that.
Thank you very much.
Thank you.
Thank you. Thanks very much, Kiara. Next speaker is Melissa Gruvotsky from the Practice Department Coordinator, Nursing and Midwifery Services, Northern Hunter New England Health District and CSIRO. And you're going to be talking about creating an implementation enhancement plan for a digital fall prevention platform using CFIR ERIC. So you'll explain what all that is. Thank you.
Thanks, Stephen. And I want to also introduce with me today is my colleague from CSIRO, Alana Delaforce, and she'll be helping me present this afternoon. So the Maitland Hospital in the Hunter Valley transferred their services to a new Capital Works build in January 2022. A significant change identified was the environment where services moved from multi-bedded accommodation to single and double room occupancy. Additionally, the overall size of the units reduced to 28 inpatient beds over 4 wards. A new technology solution to Hunter New England, Roland's Concentric Care platform, was also incorporated into the hospital build, and it consists of a speech-enabled nurse call communication system, location service engines, and digital dashboards. The solution incorporates new workflows which assist with providing care to high-risk falls patients. This is the ability to set patients within the system as a falls risk priority. Maitland had an opportunity to review their implementation approach where a research collaboration was formed with CSIRO.
So in order to evaluate the implementation, we interviewed 12 nurses across a couple of wards, including RNs, ENC and management. We recorded and transcribed them and then coded the interviews to the Consolidated Framework for Implementation Research, which is basically the result of a systematic review looking at everything that influences implementation. After coding, we generated barrier and enabler statements, so we didn't lose any context as to what that construct looked like for the hospital. And then we sorted the results using a cumulative majority. So that is the most mentioned barriers and enablers according to the number of participants. We then mapped those barriers to the expert recommendations for implementing change. Again, a list of things that experts think help address those CFA barriers. And once we collated all those 3 items, we formulated an implementation enhancement plan. And really key here is that the enhancement plan, once generated, really needs to be tailored to the unique situation. And so what that means is we start with high-level suggestions on what should address any barriers or enhance any existing enablers. And then we meet with hospital stakeholders during a co-design workshop to determine what exactly can you do here, what strategies are workable for you and in what time frame. And so that's going to look different for every hospital. And so for this particular one, I'll quickly go through some of the things we did. So for training and educating stakeholders, that meant including some simulation for using the falls system in their mandatory training. For engaging consumers, that meant integrating information into their admissions pack and using care board conversations. Adapting and tailored to context, so tweaking the intervention and modifying, say, the sensitivity of the alarms. Using evaluative and iterative strategies, so monitoring progress and using audits and then feeding that back. Utilizing financial strategies, so for example, purchasing extra chair alarms, and develop stakeholder interrelations, so integrating falls metrics and strategies into developing a clinical nurse leadership program. In conclusion, this approach helped develop a bespoke implementation enhancement plan, and again, I can't stress the importance of co-design. There was close agreement between the ERIC consensus framework recommendations and the evidence, and we believe this is likely to assist in enhancing the implementation of Roland Australian's Concentric Care Fall Prevention Platform and other similar workflow technologies. And just in closing, very positively, we have, Maitland have almost finished all of their enhancement plan actions, and so we'll be moving into the next phase where we measure quantitatively and qualitatively whether this has worked or not. Thank you.
Do we have any questions? Yeah.
Expert recommendations for implementing change. The CIFA, Consolidated Framework for Implementation Research. There's a really good website called CIFAguide.org, and it has the CIFA on there and the ERIC tool as well. So if you wanted to do this in your own setting and you did some informal focus group stuff and you picked out your barriers, you can map that to the ERIC tool and it'll help guide you to do an enhancement plan.
Is it a dashboard? No,
No,
it's more of a...
The ERIC tool sits in a spreadsheet. So I just got macro in it. So you select your barriers and then it spits out a cumulative percentage of expert agreement on which strategy is the best.
Great. Okay. So there's a website that people could look at for further
Yeah.
information. Okay. Thank you very much. Thank you. Okay, next speaker is Charlene McLennan. She's a physiotherapist at the Institute for Musculoskeletal Health at the University of Sydney, and she is going to be talking about understanding and reducing falls in the inpatient hospital setting. Hi, Charlene.
Hi, and thanks. So in line with what we heard earlier around the community, in hospitals, unfortunately, falls are also increasingly common and they're really costly and they can be stressful, if not devastating, for everyone involved. But we really need more research to guide exactly how we can reduce falls in this setting and improve our patient care. So we've conducted 2 qualitative-based pieces of work that I'm going to discuss today, and these have informed a larger trial that we aim to kick off later in the year. So the first project was an intervention component analysis that was undertaken to answer the question of what are the key intervention features associated with successfully addressing inpatient hospital falls in randomised control trials. So this work involved 31 RCTs that underwent effectiveness synthesis, coding and thematic analysis to ultimately come out with 4 features, key areas of features that appeared to be associated with more success. So they're listed along here. The first was informed implementation, which we saw pretty well presented in the previous presentation, which is great. So the idea of using co-design, stakeholder engagement or frameworks to really assist having a planned and well-planned and thorough process for embedding the intervention in the area. The next feature was active participation, and this was broken down into participation of patients and or of ward staff. The third area was local tailoring, so having flexibility in the intervention and or the implementation in order to meet the needs of patients, staff, the organisation, or ideally all. And finally, effective communication processes. So this was between staff and other staff, or staff and patients and their families. The next study was involved focus groups and interviews with Sydney Local Health District staff and consumers to work out what are the considerations when implementing falls prevention programs in the acute inpatient hospital setting. So again, 4 key areas came out that appear to be really important to consider in this space. The first was patient and setting diversity, and this wasn't just that one patient's different from another or one ward's different to another, but that a patient's needs and challenges will be really different throughout their hospital stay, and similarly a ward can look really different in the morning to the afternoon, on the weekend to a weekday. The second area was frontline ownership, so ward staff really needing to understand and believe in their role in falls prevention, and in a very similar vein, patient empowerment, where patients really need to understand their role in falls prevention and feel confident enough to play it. And finally, again, communication came through, and here we really heard a lot about communication between interdisciplinary teams and communication between staff and patients, but even more so staff and patients' families. So these 2 studies have informed a large trial that we have planned for later in the year that's known as the Protect Falls Project, so prevention through education and coaching in a stepped wedge trial. This is a partnership project that's received 3 years of NHMRC funding and is involving South West Sydney Local Health District, Sydney Local Health District and the Clinical Excellence Commission. We have a suite of aims. The first is around co-designing the implementation strategy. Then we've got aims around evaluating the effectiveness in terms of fall rates and falls injuries, looking at other implementation outcomes, and then finally cost effectiveness. So stay tuned for more information on and more details on that. And that's it. So thank you to my supervisors, to collaborators and to all of our participants.
Any questions from the floor? Can't see any. I think it's late in the afternoon, but we look forward to hearing a lot about the Protect trial in the future. Thank you. Okay, so our next speaker is Megan Ambryn. She's a postdoctoral fellow from Neura, and she's going to be talking about how perceptions of ageing influence physical activity and exercise in older age.
Hi everybody, thanks for giving me the opportunity to talk to you. There's a lot of detail on that slide, so you have one slide from me. Let me explain what this study is and why we did it. Out of the Standing Tall trial, we started to hear about, when we started to talk to people about what they thought about engaging in the Standing Tall trial, we started to hear a lot about age and ageing and how people felt about that. When we went back and had a look at the literature, the systematic reviews that are out there, when we look at barriers to why people are not engaging or engaging in programs like fall prevention, we don't see anything that's matching what we're hearing from participants. There was a systematic review by Franco that looked at what influences physical activity participation. They talked about environmental factors and they talked about financial factors. So Standing Tall takes away both of those things. It is an online program that delivers a fall prevention, exercise-based balance exercise-based fall prevention program. We gave people iPads, that were internet enabled. We took away those barriers that are previously identified. But we still see that people stop engaging, or we don't see enough engagement in fall prevention and physical activity. So we started to say, well, what is it about, what else is influencing health behaviours, their physical activity health behaviours? We went back to the data we'd collected, and we start to see that people's perception of ageing influences their health perception, their activity perception. It influences as an overarching theme. It also influences their physical activity in older age, and it influences the way that the delivery of exercise, what they're looking for, what they expect they can do themselves, what they expect a physical activity program to look like. Why does this matter? Because people aren't physically active. What we're seeing is really, really great research, and people engage in it for the duration of the trial and then they drop away. And we need to start to think, how else can we think about these older people? What else is influencing the way that they're thinking and therefore the way that they're behaving, rather than just environmental factors or just financial factors and the things that we've traditionally looked at in terms of how we design programs. So our takeaway is that ageing seems to be, and the perception of ageing seems to be something that people are thinking about, and something that as they age, and something that we as people who either design physical activity programs or deliver physical activity programs in the clinic need to start thinking about, need to start understanding who is the person that's standing in front of them and how is their experience of what's happening to them on a daily basis influencing the way that they're behaving and the way that they're thinking. That's all.
We have time for a question or two. Anne, hi. Lloyd, do you have the mic? Just down.
Thanks, Megan. More a comment than a question, but what I'm noticing today is there's a lot of talk of the one size doesn't fit all, and I think it's been a theme of today. And really thinking about the fact that, you know, as people get older, they get more diverse and they have their own stories that they bring to the situation, and we need to consider all of those things when we're trying to change behaviour. But thank you for your interesting and thought-provoking presentation.
Thank you. Anybody else? Just here. Sorry? Oh, so, yeah. What was the age demographic?
Of your team.
In our research team? Probably me. I could be the oldest person in our research team. Sorry? Only if you go back and ask no. Every other person. I am in my 40s.
So it's just interesting because I'm starting to open a business that looks after people who are over 60, and I am 60.
Yep.
And it makes an enormous difference for you to be the person who says, I say to them, this is self-interest, this is what I want to happen when I get to 75. And I think also as you get older, you have more time to listen to people's stories and you don't find them weird. It's just a concept that maybe you just need to be thinking on your research team, do you need to have a greater diversity of age with the people that you approach? The people that use the research, a greater diversity of age when they approach your client.
Maybe. Yeah, maybe. I think it's something that we haven't really thought about before, and I honestly think it's the people in the community are thinking about it. They're experiencing, you know, as people age, they're experiencing ageism. We see it, you know, like we see it. We see it in the media. We see it in terms of who's reflected back to us on our TVs. We see it in print. We experience it as we go about the community. I've just done this. I'm doing an ageism study as well, and you know, people start to say to me in their jobs. I started interviewing people from 50, and they said to me, you know, once I can't get employed anymore, and like it's a really significant factor that I think we need to start thinking about the person that's standing in front of us and start to think about some of those other factors when we've got increasing falls and lowering physical activity levels, and what is going on for these people.
Just looking at you. Thank you. Thank you, Megan. I think that also comes back maybe to the issue of co-design as well. Right from the beginning of trials, it's another factor that's certainly becoming more and more crucial in falls research. Okay, we're going to do a bit of a switch now to Vision, and Jessie Huang Lung is our next presenter. Hi, Jessie, and she is going to be talking about the true cost of hidden waiting times for cataract surgery in Australia. Thank you.
Good afternoon, and thank you to the meeting organisers for the opportunity to present this research on behalf of my team at the School of Optometry and Vision Science at UNSW, our collaborators at the George Institute, Melbourne University, Westmead and Sydney Eye Hospitals. This work sort of follows nicely from the presentations this morning by Professor Lisa Key and Kerry Martin. So, Cataract is a clouding of the normally clear lens of the eye and is one of the most common causes of vision impairment in older adults. Cataract causes blurry, dimmed vision, making it more difficult to judge depths and edges, such as stairs, footpath edges, and other floor-level hazards. As a result, people with cataract are at a greater risk of falling. Fortunately, cataract can be treated with surgery, and there is evidence to show that cataract surgery can reduce the risk of falls and also of motor vehicle crashes. However, currently access to cataract surgery is inequitable. In Australia, about 30% of people access cataract surgery in public hospitals as public patients. While in the private system, patients can have surgery within weeks of diagnosis, public patients can wait from 4 months to 2.5 years, depending on the state or territory or the hospital that they attend. So in our study, we wanted to demonstrate to policymakers how different surgical waiting times could impact on incident falls, motor vehicle crashes, and also health system costs associated with treating the fall and crash-related injuries. To do this, we used estimates of fall rates, crash rates, and health system costs from published reports, Australian government reports, studies done in Australia, and other sources. So over a 3-year period, we compared outcomes for 2 scenarios, a 3-month wait for cataract surgery versus a 12-month wait. So from the National Eye Health Survey and ABS data, we estimated that over 75,000 people were currently living with cataract and would access surgery through the public system. The total cost of performing the same number of surgeries, pre-operative and post-operative consultations, would actually be $13 million higher in the 3-month wait scenario compared to the 12-month wait scenario. And this is due to the applied economic principle of discounting, where future costs are discounted at a rate of 5% per year. However, this would be offset by the $20 million in cost savings that we would get by avoiding over 50,000 falls. Interestingly, the number of crashes, motor vehicle crashes, was slightly higher, resulting in a slight increase in health system costs. But all in all, if we look at the bottom line, it suggested a modest savings of $6.6 million to government if waiting times were 3 months instead of 12 months. So in conclusion, this study found that by eliminating unnecessary delays to cataract surgery, this would lead to better outcomes for patients, reduce falls, and also alleviate an economic burden on the health system. Thank you.
Thank you. It's a very good use of available data. Just stay just one moment. Okay. Yeah, and very clever, and another sort of powerful tool for advocacy. Any questions? If not,
Yep, I'd love to ask a question. So, wondering where the information came from about cataract surgeries reducing the incidence of motor vehicle accidents and why that wasn't shown in your study.
Why that wasn't?
Yeah, you showed an increased number of motor vehicle accidents.
Oh, yes.
come back to the mic.
The opposite.
Yeah, so we estimated that from the 4th reference there, and it just related to the finding that crash rate was actually higher after having second eye cataract surgery, slightly, compared to after first eye cataract surgery. And the thought behind that was when people were in between surgeries, only having had one eye surgery, they may take less risks, do less driving because of the asymmetry. But once they've had both eye surgeries, they might be taking longer trips, doing more driving. So that was what we thought it could be. Thank you.
Makes sense, I suppose, just increased exposure and therefore, I guess, a few more crashes. Last talk of the day, and appropriately, it's about avoiding God's waiting room. So that's what we're finishing off with. So we have Abby Haynes, Research Fellow from Sydney Musculoskeletal Health, University of Sydney. Here she is. And the talk is Avoiding God's Waiting Room, Lessons from the Lived Experiences of Older People Who Use Technology to Support Physical Activity. Welcome.
Hi everyone, I'm keenly aware that I'm standing between you and your weekend, so I will cut to the chase on this. I'm going to tell you about the findings of an interview study with older people who reported regularly using technology to support their physical activity. This topic's important because the literature indicates that older people are accepting of and adhere more to exercise programs that are supported by technology. So our data analysis identified 4 main points. Interviewees were adamant that older people should embrace technology. They gave many examples of how they were using it to support and motivate physical activity. Personalised data boosted feelings of achievement and validation. Entertaining audio acted as company or distraction during exercise. And the internet provided access to a huge range of online classes and videos. And they generally found their preferred activity many years ago, but introduced technology more recently to support it. Pathways to this tech often involve family and friends who introduced, encouraged, and modelled tech-supported behaviours. They shared activity data, and they recommended or joined interviewees in online classes. Adaptivity was a conscious stance. Interviewees had modified their activities and their use of technology in response to changing physical abilities and challenging circumstances, including COVID impacts, of course, which cut off access to many preferred physical activities. And they differentiated between getting older and inevitability and acting like an old person. They aimed to accept the realities of aging while simultaneously refusing to give in to them. And this was fueled by personal philosophies of healthy, active aging, which were powerful enough to overcome intimidation by software and apps. But the technology they used was often poorly attuned to older people's needs. Yet only one interviewee argued that this was down to the tech design. Most blamed themselves. They explained they were technologically incompetent. Luddites, technophobes, who weren't as smart as their phones and didn't use their devices optimally. And this was exacerbated by physiological and cognitive challenges. So their efforts to both counter and accept aging were complicated by technology's double-edged sword, which increased connectivity, access, and self-determination, but also could be overwhelming and highlight people's limitations. So our findings suggest the value of leveraging family and peer support and using tech for physical activity. Health professionals could play a greater role in reinforcing philosophies of active aging. And any encouragement has to take a strengths-based approach that emphasises the capabilities that we saw in our study: resilience, adaptivity, and good enough competence in using technology. There's also huge value in involving older people as co-designers in the development and testing of these technologies and in co-designing strengths-based programs that promote their use. I'll just leave you with a paper from this study.
That was fantastic, and some wonderful quotes you had there. They're really good. Another issue I notice is just the size of the font. You know, it's just nothing to do with cognition if you just can't see what's on the... So I see better without my glasses these days for those sorts of things. Have we got any questions before we wind up? Yes.
Yes, I'm Barbara and I'm 85 years of age. I wonder what's happening next to my body as I get older, but exercise has to be fun with music. Music's a wonderful tribute. And don't forget, as you get older, you're not an embarrassment to your children if you do exercise. Thank you.
Barbara, did you attend any of the dance sessions today?
I love dancing, but I've lost my husband, so I've got no one now.
Okay. Last chance for anyone to talk, make a comment. Otherwise, I think we're just about to finish up, and the last...
Just a quick question.
Oh, sorry, I can't see. Yep.
So just that one of the quotes from your participants saying, you know, my eyes don't work as well as they used to, etc. Mobile phones have a lot of accessibility functions that are routinely used by people who are blind or partially sighted or otherwise have low vision. Is there any integration of like training and support to utilize those accessibility functions for people that are using digital technologies for these contexts?
That's not a question I can answer, I'm afraid. These were community dwelling people that we recruited via survey. This wasn't an intervention. So we certainly weren't offering anything like that. We were just finding out about their lived experience. But I'm aware that many of the people we interviewed felt that technology was designed for younger people, by younger people, and they didn't necessarily look to those accessibility options.
Thank you very much, Abby. Thank you. Okay. So the last thing, we are actually on time, so we're just going to close the meeting and hand over to Lorraine for this.
Thanks, Stephen. Yeah. Thank you, everybody, and I know that it's been a jam-packed day. We've heard a variety of different presentations working towards improving outcomes for older people. We've been through the research and the evidence that's emerging around increasing physical activity and options for preventing falls and harm from falls. I do like John's comment around optimising ageing, how we support people to live independently and well in their older age as best as they can, depending on their conditions. We know that there are emerging new guidelines that we're going to have in Australia at the end of this year. Thank God we've moved beyond the green box, Steve, so thank you for that. Those of you who were around in 2009 when we launched the Australian Fall Prevention and guidelines, there's a lot of work that we did at that time, so I'm really encouraged to see and to hear that they've been updated. That's going to be really excellent for us because it's good evidence now for work we can do in our community, and you've heard a lot about that today, what we'll be doing in resi care, and also what we can drive to improve in our hospital settings. For those of you who missed out, and you did miss out, on the dance session in the resi care section this afternoon, I'm very sorry you didn't participate. It was really invigorating and exciting and a lovely way to do exercise, so I thank you for that opportunity to participate. Before I get on to one final thing, we have an evaluation there. I do hope you're filling out your evaluation forms. It's really important for us to have feedback because we tailor what we get from you as to what is emerging, what you want to hear about, so we can plan that for our next year forums. We are going to be doing some rural forums, and we're planning now, working with Nicola and Joe from Southern New South Wales, to deliver one at the end of the year in Southern New South Wales. And we probably will make that virtual as well. So look forward to that. I'd just like now to thank a few people. So particularly I'd like to thank, this doesn't happen on its own. And the person behind making this happen is Natasha. Where are you? Tash, please come up. Some of you won't have met Tash yet. She's a bit of a dynamite, really. As all our project officers have been. So, Tash, thank you so much. Thanks. Don't do it to me. So she's worked very hard, but I do also want to just acknowledge that Cameron's with us today too. Cameron was our project officer for many years. Prior to that was Esther. Cameron's now working with Stephen, who's now progressing to do his PhD, so it's great to see you here, and we wish you well on your journey through your PhD travels, and then hear you presenting that work here at some stage as well. So it's time to go. I want to wish you well. I want you to go home, go well, be inspired, think about what you've learnt today and what you can take back to your practice the next day you're working. So whether that's tomorrow or on Monday morning, what is it new that you've learnt today that you can implement into the work that you're doing? Think about it. We'd love to see what change. You are our change agents. You are our future as well in driving improvement. So thank you. Travel safe. And enjoy your weekend. Thank you.
Okay, I was like, what to do?